I think the government will listen to this. The nursing education should be streamlined so that we have, we don't need this fragmentation of a registered nurse, a registered midwife, a nurse who has just done only psychiatry. We need just one comprehensive nurse who has done community, who has done nursing, who has done community, and who can now specialize in whichever now field they want. But we are asking the government, kindly, for the sake of the nursing profession, we just need one cadre of nurses.
An estimated 1.1 million Kenyans fall into poverty each year. And that's because of healthcare costs. Would SHA, SHIF, UHC change that, or is there more? Or perhaps, what's the difference between a pharmacy with a Blue Cross and a Green Cross? What about cancer and the rising incidence amongst the youth? Is it just lifestyle changes, or is there more? Women's health, men's health, your children's health, the economy, this and more awaits you on Season 2 of Kenya's favorite health podcast. My name is Dr. Diana Wangari-Gitau, and welcome to Season 2 of the One Health Lens podcast. Hello, welcome to the One Health Lens podcast, where we have conversations around health and related topics, making them simple and easy for you to understand. I'm your host, Dr. Diana Wangari-Gitau.
And I am Dr. Simon Moshara Kegondu.
In this episode, we'll be having a conversation around, the largest human resource for health, that is nurses. We want to understand the nursing practice in Kenya, what's happening, right? We want to hear their voice because a lot's been happening in Kenya in terms of health. There's been a lot of movement, I think, and it's about time we had what's happening. And in studio with us is a very important guest. A very, very important guest. I'll let him introduce himself and we'll get going. Go ahead.
Thank you, Diana, for the welcoming. My name is Collins Otieno Ajwang. I'm the president of National Nurses Association of Kenya. I'm glad to be in this show.
Thank you. Thank you so much, Collins, president of the National Nurses Association of Kenya. Yeah. I mean, let's start from, it's always easy to start from the beginning because then most people would want to understand what nursing practice in Kenya looks like, right? Let's even start from training. What's the kind of training that's available in Kenya? I understand there's different, cadres, specialties. Maybe let's start from there. What kind of training, first of all, is available in the country?
Thank you, Diana. Nursing practice started long back in Kenya, way back before I was born, and I'm glad to be a nurse.
Yes.
And it is by choice that I made a decision, and many of us made decisions to be nurses. I want to appreciate the nursing profession for the good work they are doing in our healthcare delivery system. To be a nurse is not easy. And it is a task that you need to be ready for it, and it's just beyond the usual work practice that we are having. To start with, nursing profession, to be a nurse, the training starts at different levels, but most people started at a very noble level, a very noble cadre of at certificate level. So in the certificate level, you start from the certificate, then you have the career progression has already been opened. You can go to diploma. From the diploma level, you can take your first degree, you can go to masters, and you can do your PhD. And we have got our regulatory body that is controlling the nursing practice. And the Nursing Council of Kenya is doing a commendable job. And it defines the scope of nurses in various cadres, and it also defines the entry level. So to be a nurse, there's you at the entry level, at certificate level, you start from a C minus to go into to start your certificate course, and there are cluster subjects that you have to pass, including languages, biology, and science subject, and this is like mandatory. Even if you attend a mean grade in your KCSE of an A, and you fail to attend the minimum entry grade or in the subject cluster, then you cannot be a nurse in any of those levels. So the other, also in diploma, you start from, the minimum requirement is a C, and with the obvious, the required subjects, there's a mean that you have to get in those required subjects. So it is important to know that there are those that you can start at certificate and go all the way, and that there's also in the nursing education and training, you can also start from diploma, and you can also start at bachelor's and progress further. So the training is wide. It takes, like in certificate course, you take, we used to go for 2.5 years. Right now it is 2 years. But the hours, the course duration still remains the same, even if it is 2 hours, but the course duration still remains the same. So it also goes to diploma level. We used to take it for 3.5 hours, so between 3,900 hours, and it is the same, though it has, the diploma has reduced to 3 hours, and still also at a bachelor's level, the mean grade is around, minimum is around C plus. And you can you take it for around it is a 4-year course with 1 year of internship. So it is a very intense program.
Absolutely. I mean, I agree with you. I'd have to commend the nursing profession in Kenya, because even as a doctor, I know the person who, and Kigondo shouldn't hear this, but yeah, the people who really not support, who even train us, give us skills, tend to be nurses, right? When we're in our internship period, the person who's helping me as a young it's always a doctor, a nurse, right? I mean, you go to most of our facility, you definitely will find a nurse, right? When you even talk about the backbone of communities, most people will know my neighbor is a nurse, first I'll go to her before we go to doctors. So it is, yes, a humble profession, but it's commendable in terms of just how much both the association, the council has done to just support that large network, right? So in terms of just maybe give us the landscape, what's happening? We understand the training, what has been happening, because obviously the numbers have grown, right? There's a few things you've seen in the news, and before I even mention them, maybe let me ask, what's been happening in the nursing profession? What's been happening?
For a long time, the nursing profession has been dogged by several challenges, and the gaps that are there include ratios, and we Kenyans have this health-seeking habit where they want to go to the health facility for any reason. So the numbers has increased so much of the clients and patients seeking healthcare, but this has not been directly been supported by the health workforce. So employment has been dwindling, and the numbers of patients and clients have been increasing. And if you see the demographics, the government has not been employing since devolution. The government there's been a wide batch in employment of health personnel, and this has really had a negative impact on the nursing profession. So in our previous strikes, we have been agitating for more employment of nurses to address the healthcare needs in our societies. And it has always been like the nurses are on strike for their own benefit, but it has not been so. We have also been on strike to make sure that we have been given an equal opportunity on the trainings. Like Dr. Kigondo here knows that when his people have already graduated and have been absorbed, they stay in one job group for just 1 year and they go for further training. It has not been possible for the nurses. So nurses have not been getting these opportunities for trainings, and that's also has been a cause of conflict between the government and the nurses. So the issues of ratios because of lack of employment. The internationally we have got a norm where and it is something that has been documented by the World Health Organization that you have in ICU there's a specific ratio of a nurse to patient that is 1:1. In HDU, one nurse to take care of 2 patients. In general wards, we have got 1 nurse taking care of 5 patients, and etc. etc. But the ratios of nurses have been going down without replacement, while the patients have been increasing, and so these are the issues that has been making nurses to feel that there have been their issues are not being addressed. The other issues you have seen that came, including where COVID-19 came, and we were like everybody was exposed, and the risk allowance is so small. You don't compare risk allowance of a nurse to the risk allowance of other healthcare professionals. Nurses get 3,850, while they have to bear the brunt of getting so much contact with the patients for so many hours, while other healthcare professionals get from the range of 10,000, 15,000, some get even 50,000 for just a short stay with the patient. So these are the issues that we are saying, that there is a discrimination on the people who actually are there with the patient, getting exposed vis-a-vis the other professions. So we need a level playing field, because a disease does not know that you are a doctor, you are a clinician, you are an anesthetist, you are any other cadre, you are a consultant, and the other professions. So we need a level playing field in that line. We have also been saying that as nurses, we need our directorate. There's an explicit Health Act of 2017 that covered and said specifically that nursing should be a directorate. So the successive governments have not really appreciated this, and they have tried to hide behind so many other directorates by leaving out the nursing profession, and we are the majority in this profession. So the thinking was that it is important to give the majority their share. So that healthcare simply is about getting the majority to take care of the rest. So we felt that the directorate of nursing could have taken care of so many things in nursing and to address these gaps. Because you go to a hospital, the first person you'll meet is
definitely a nurse.
And definitely the last person you'll meet there will be a nurse. And when you go to maternity, you know the obvious. The first one that goes to
the nurse. Yes.
So this director could have solved so many things. So right now our issues have to go through convoluted channels until you get to where you want it is. But when you come to the household, you also get that whatever you'll ask for, you'll ask the nurse that, can I get this? Can I get this? And you have rightly said, Dr. Diana, that when you were in your internship, the person who took you through the process was the nurse who was there. So the issue of getting the nursing profession to be recognized has been a challenge. And these are the issues that nurses are really concerned about. And then the issue of the job opportunities. When they come, the terms of service is not really encouraging. Right now, we prefer permanent and pensionable so that somebody has surety of a job. But the current system of contracts are not so much pleasing to the nursing professionals. The nursing professionals have also looked at the scheme of service. Currently, we are calling it a career progression document. It has really overstayed. The current one we are having was done in 2014 by the Professional National Nurses Association of Kenya, but it has since expired. It does not really appreciate the dynamics in the nursing profession and the changes that has come with it, because right now we have got much higher space in our career progression. Previously, we did not have the masters, nurses who are done masters and above, which currently needs to be captured in the scheme of service. And also there are other specialities that has come up that needs to be appreciated in the scheme. So currently, we need that document to be looked at and then to address the current, the reality in the current situation that we are in. So, I've also talked about training. We need equal opportunity so that nurses can be given opportunities to go and further their education and their specialities. Previously, when you come to the nursing profession, after 2 years in service, you are encouraged to apply to go and further your education and specialize. Right now, it is not the case. Yeah. So these are areas that we need to be given to be supported in. And then, Dr. Yana, you can see that in administration, and we challenged this and got a favorable ruling. In administrative and positions in leadership, it was basically designed by design. I think it was given to one
let's not even mention which cadre. Let's not mention.
So you see, it was totally discriminating to the nursing profession. So we challenged this, and the judge made a favorable ruling that every healthcare professional has an opportunity to take leadership in leadership position in whichever level, but in reality it has not. It is not. Yeah. So these are the issues that we are raising.
We are battling with.
So currently, as we welcome the new CS, we want the new CS. She has everything. She has a lot in her plate.
On her plate.
But we would like the new CS to start thinking of making the profession to grow by bringing nurses on board. Have nurses also to get appointed in these senior positions. It is important for the growth of the profession.
I agree with you. Kigondo.
So, thank you very much again, Collins. We've been journeying together. So I think he's a good representation of the nursing profession. I have conflict of interest because over and above being taught by nurses, as you put it, I acquired a nurse for myself as a night nurse and permanent
resident in your home.
In my home.
Yes.
And I think that has really been very useful. Many people will tell you that a lot of where I am is as a result of my permanent resident, who happens to be a nurse. Nevertheless, that said, personally, I think nursing has come a long way. In the year 2010, was it 2010, when we used to do a combined supervision as a district medical services officer of Isiolo. We once visited a hospital, which was at that time we were doing the assessment of hospitals. It was being run by 3 nurses. So we found a hospital with 400 patients, 3 nurses running, and they were, as Collins, I usually enjoy them, so to speak, that the top nurse there is the one who had KRCHN. That's the qualification for nurse. And she was the one who had the basket of collecting the 20 bobs. She was the one dishing out the money. So it was really sort of basic and rudimentary. The second one, who we were calling the workers, so to speak, was an enrolled nurse. So there is that course of Kenya enrolled nurse, and she was, of course, in the maternity family planning unit. And then there was a third one who was really, she had, I think, done nursing a long time ago. I used to say she has EN. You know, there is ECN, KRCHN, and EN. So in this hospital where we found these three nurses, and that had been a structure for a long time in the country, where nurses generally ran the health facilities across the country. Of course, after that, it was the time of performance contracting. We, of course, sent a doctor, 2 clinical officers, and 10 more nurses to the unit, because that unit could not be run by 3 nurses effectively. Now, the nursing profession has gradually improved. Not improved, they've gone with the times, so to speak. So as Collins has said, there was the dressing, pre-colonial, then later they moved to the EN, then the ECN, I think, in terms of then the Kenya registered community health nurse, and then the degree nursing. In my view, and just maybe for Collins to comment on that, a lot of the issues we face, both as a country and health workers, is remuneration. Generally, all health workers are relative to what they do. The remuneration is not sort of in keeping to what they do. And therefore, for the nursing profession, who are probably luckier than the doctors, they have the opportunity to go out there where remuneration for nursing is good. So if you go to the United States of America, Britain, you'll find even doctors who go there sometimes change and start doing nursing duties, and because the remuneration there is flipped. Probably they actually recognize the importance of nursing. And nursing, yes, does form the cornerstone of the medical profession. Doctors can go on strike. All health facilities will not close. But when nurses go on strike, now all health facilities do close. And that's why once in a while we like to call upon them to help us when people are disturbing us. But they usually refuse. They have their internal domestics where they don't go on strike when they are supposed to. But yeah, so that's my take on
we said we just don't go on strike because
like
doctor can go on strike. We have
that's my take on the nursing profession. And finally, I have worked across the whole range from the lowest health center place to the highest hospitals in this land, and of course, you know, the biggest private hospitals. And when we work in the maternity, a well-trained, well-motivated midwife is the greatest asset that the doctor can have. And I'm sure, you know, when you go to those things, then you go to second stage and you get a shoulder dystocia. You would want that you have the midwifery team who are actually knowledgeable in that and know what to do in place. So for me, what is missing currently is the continuous training and education, empowering of nurses, better payment for the nursing care that is done, so that we can really have a better health system.
I agree with you. I mean, one, the fact that they are the cornerstone, because I remember, was it 2007 when nurses went on strike and everything shut down? You know, it was really, really bad. You know, it was. And I agree with you around getting well-trained, well-motivated nurses is key. Because, I mean, any mother who's delivered knows. I think that would be the perfect example. If you don't have a nurse or a midwife, as the case might be, who's there, who knows, it's not relying on calling a doctor, but who knows that if I see this, this is what I should look out for, right? But more importantly, it's the fact that, as you said, Isiolo, 3 nurses, right? That's 2010. But even now, we know that you go to the farthest health center in this country, it's a nurse you'll find, right? So back to you. when you hear from nurses, right? I know you've presented the issues, right? Is there, because let's call it a wish list to the new CS, right? Is there, what would be the priority? Because obviously there's a lot that needs to be covered, and probably it's going to be systematic, right? But where would she start, right? Where should she start?
I think first and foremost, I want to congratulate the news incoming CS.
If she's confirmed.
Yes.
Yeah.
Yes. I want to welcome her to a new job at Afi House as our CS Health. And I think for a long time we have said we have never been listened to. Yeah. I'm happy that she's a mother. And I'm happy that mothers do listen a lot.
Absolutely.
And we have tried on several occasions to reach out to the government to listen to the plight of nurses. I'm also glad that during the pre-election campaign we had the professional associations and the unions, health associations and unions, who met the current president, Honorable William Samoei Ruto, and we had a candid discussion on how we need to move the healthcare forward, and we got him to listen to us, and I think from there we have had several high-profile advisors who have been really focused on making sure that we achieve the UHC agenda. And at a point you were thinking that we were going places until we ran into roadblocks.
Bottlenecks.
It is not the end of everything. We welcome the new CS, but we want to tell her that she is coming on board. We would like first to have an audience with her to tell her our plight. Two, we would like her to involve the president on this, so that we have also a round table discussion with the president, the way we had during the pre-election, so that we can draw a new work plan and roadmap for to build health for the prosperity of the nation and our people, because in between we are losing out on a few things that we need to catch up on. One is there's the issue of UHC. You cannot just go and start implementing UHC without the nurses' involvement.
In fact, it will collapse before it starts.
It will. It is a stillback, and that's what the challenges we have on the ground. Because there's a new team that has come on board that wants to build UHC under primary care networks, which is good, but there's no nurse involvement in it, so making it very, very difficult to implement. I can tell you, you cannot train somebody in 3 weeks to learn what we have learned in 3 years.
In 3 years,
and then
expect the same
results. This person, you expect this person to assess and diagnose and implement, because they are being given everything. So it is not easy. That's why we are having we have gone back to a lot of maternal mortality, and HIV is coming on board because there's no advocacy. There's so many things. We have got a lot of pediatric mortalities, and we are deranging, and we are in every aspect. So we really want to have a candid discussion with the CS, and also to invite for us the president, so that we can have a meeting together.
Absolutely.
And also, there's as she's coming on board, we'll ask nurses are the ones working. Majority, you'll never see Dr. Gigondu is a senior gynecologist, but he's only one in his field. But we have got several nurses who have specialists in midwifery, who are specialized in reproductive health, who are managing most of those health centers in level 1, level 2, and in level 3 hospitals. Most patients, the first contact they'll meet with are with these people. And then upon assessing and diagnosing the problem, that's when, if the nurse cannot manage at that level, they refer to the next facility where they are going to meet Dr. Kigondu. So it is important that we appreciate the nurses and involve them in implementing and managing of the UHC in our country.
Collins, last message, right? Final message. Kigondu, we leave him. Final message. Tell me, what would be the final message? Tell us. Or call to action.
Yes. I think, thank you for the platform. And I think the government will listen to this and all the stakeholders. I've got just 2 issues to put across. One, that the training of nurses, currently, as this is to the members of the public as well, that Dr. Kigondu alluded to it, though he did not bring it out completely, that the nursing education should be streamlined so that we have, we don't need this fragmentation of a registered nurse, a registered midwife, a nurse who has just done only psychiatry. We need just one comprehensive nurse who has done community, who has done nursing, who has done community, and who can now progress and specialize in whichever now field they want. I know the government has a lot of interest in nursing education, but we are asking the government, kindly, for the sake of the nursing profession, we just need one cadre of nurses who are one community of nurse with all these specialties. We are finding it very challenging that there is a nurse who has done nursing completely, comprehensively, but there's also somebody who has done just midwifery, or somebody, a direct intake just to do psychiatry. These people are getting disadvantaged because outside employment, the counties will just employ a nurse with all this comprehensive education. But if you disenfranchise a nurse to give just one specialty to do, it is really bad. So that's my first take. The second thing is, we have had cases where there's some opportunities for training of nurses. We ask the government to make sure that the allocation for nursing education and practice is enhanced. The third thing is the nurses' safety at workplace is becoming a very serious problem. Because they work in very far-flung facilities and etc. A lot of challenges are there. The safety and security of nurses who are working there is really of paramount to us. The other one is the career progression document, the scheme of service. It is very important for us that we have a progressive scheme of service that nurses can be proud of, that enhances their capacity, their remuneration, that they can really feel they are appreciated by the government of Kenya. Well motivated, well remunerated, that they can take care of their bills. The government is able to pay them on good time because they are there 24 hours for the patients. They don't have time for those locals.
Cornerstone of the healthcare medical profession, as Kigondu said. I hear you, Collins. It's not a nurse's issue. It's if we can find a way to have a collective voice as the human resource for health, especially in this journey towards UHC. We will in court unawares, as you say, right, that primary healthcare is being rolled out, or primary care networks are being rolled out, but the nurses are unaware, you know. So I think unifying and giving our voices as a collective voice is key. Sure. Collins, asante.
Thank you.
You're coming back again.
I will.
Asante sana. Thank you so much for joining us on the One Health Lens podcast. We'll see you next time.